We have with us Dr. Kenneth Li and Dr. Tracy Lai, Dr. Kenneth Li is Chief of Service of Ophthalmology, and he's a consultant ophthalmologist, and Dr. Tracy Lai is an associate consultant. So whenever you're ready, you can introduce yourselves and begin the presentation.
On behalf of our team, I would like to thank the Argentinian Council of Ophthalmology for their kind invitation. Thank you, Leonardo and Luciano, for their wonderful arrangement. I'm Kenneth Li, and with me today is Tracy Lai. We're both from the Department of Ophthalmology at the United Christian Hospital and Zhengguan Hospital in Hong Kong. Tracy and I work for the Hospital Authority, which is a public health service provider in Hong Kong, equivalent to the National Health Service in the UK. Our Hong Kong team provides ophthalmic service to the Eastern Peninsula of Kowloon, with a population of around 1.1 million. Before I start, I would like to thank all my team members of the Department of Ophthalmology, Pathology, and Infection Control for their great effort. They have been working very hard over the past 2 months to implement infection control measures to minimize transmission of COVID-19 to both patients and staff. This is the outline of our presentation. Tracy will go through the background of COVID-19 and its implication for ophthalmology. I will go through the infection control measures, and we have prepared some useful links for you at the end.
So let me start with some basic terminology. COVID-19 stands for Coronavirus Disease 2019, and it refers to the disease and having a positive laboratory test regardless of the signs or symptoms. SARS-CoV-2 is the gene bank name for the virus. The gene bank is the genetic sequence database of the National Institute of Health. The SARS-CoV-2 is a coronavirus in the same family as the severe acute respiratory syndrome virus and the Middle East respiratory syndrome virus. It is 65% identical in nucleotide sequence to the SARS-CoV virus in 2003. Let's talk about the history of COVID-19. The first case was reported in late December in China. There was a cluster of 44 patients with pneumonia of unknown origin, reported from Wuhan, Hubei province in the central part of China, from late December to early January. It quickly emerged into a global pandemic with over 300,000 cases as of today. This is a map of the confirmed cases. China tops the table with over 80,000 cases, followed by Italy and the United States. Hong Kong now has 273 cases and Argentina has 225 cases. There are over 300,000 confirmed cases now all over the world, and less than 1/3 of them have recovered. 13,000 people have died, and out of the 200,000 active cases right now, 10,000 are in serious or critical condition. Next, I'll move on to the clinical features of COVID-19. This is a study published of the first 425 patients with confirmed COVID-19 in China. The median age is 59 years old and the mean incubation period is 5.2 days. And it is notable that almost half of the cases were adults of 60 years of age and older, and children are less likely to become infected. And the adults in 60 years of age or older are in a very high risk group. And the majority of the eye patients at our clinic are over 60 years of age. Common presentations of COVID-19 include fever, fatigue, and dry cough, and a minority of patients present with diarrhea, shortness of breath, and hemoptysis. Complications include acute respiratory distress syndrome in 29%, and this is the major cause of death of COVID-19. Other complications include anemia, acute cardiac injury, and secondary infection. Regarding morbidity and mortality, the onset of symptom to deterioration is 9 days on average. Around 80% of patients have mild disease and full recovery. However, patients with premorbid conditions such as diabetes, heart disease, hypertension, history of stroke or malignancy have a higher risk and worse prognosis. And the mortality increases significantly with age, and rising to around 15% in patients over 80 years old. The overall mortality is around 2 to 3%, but the mortality in hospitalized patients is around 15%. For the routes of transmission of the SARS-CoV virus, from the experience we learned from the MERS and the SARS coronavirus family, it mainly transmits through droplets, contact, and fomites. And it is not airborne under normal circumstances. For contact transmission, it occurs through direct contacts with secretions from the infected cases, followed by subsequent inoculation in mucous membranes. And fecal-oral transmission and aerosol transmission are unconfirmed, but we need to take precaution. Maternal-fetal transmission is possible. And asymptomatic individuals are capable of transmitting the disease, as evidenced by nosocomial transmission and transmission among asymptomatic healthcare workers. And family clusters of cases have been reported. Next, we'll move on to the characteristics of the virus. It is sensitive to ultraviolet light, heat, 75% ethanol, ethers, peracetic acid, chlorine, and chloroform disinfectant. The virus can live for hours on shiny surfaces and up to 5 days under conditions such as 20 degrees Celsius and 40% humidity. As the use of mobile phone is vital to our lives nowadays, it is a possible route of transmission of the virus. Next, I'll move on to the implications for ophthalmologists. A minority of COVID-19 patients have conjunctivitis. In a study of 1,100 COVID patients from 30 hospitals in China, 0.8% had documented conjunctival congestion. In another preprint study of 534 cases in China, 4.68% presented with conjunctival congestion, and 3 patients had conjunctival congestion as the initial symptom. The average duration of conjunctival congestion was 4.9 days. And besides conjunctivitis, dry eye, blurred vision, and foreign body sensation were ranked as the top 3 other related ocular symptoms. And 62% of these patients had a hand-eye contact history. Below are some examples of conjunctivitis as the first symptom of COVID-19. In the photo is Dr. Guangfa Wang. He was a Chinese expert panel member who visited hospitals in Wuhan in late January without any eye protection. He developed conjunctivitis 3 hours before the onset of fever and cough. And another anesthesiologist in China did not wear eye protection during intubation of a COVID patient, and she developed conjunctivitis before coming down with fever and cough. Therefore, it is possible that conjunctival transmission occurs by droplet or aerosol transmission. And another study by a Chinese group They studied the PCR samples of the conjunctival and tear secretions, and they found that 1 out of 30 samples tested positive for the virus in tears and conjunctival secretions. What's alarming is that asymptomatic patients are also capable of transmitting COVID-19. There was a familial cluster of 5 COVID patients in Anyang, which is a place far away from Wuhan, and they are suspected to have contracted COVID-19 from a relative, asymptomatic relative, who visited Wuhan previously. And ophthalmologists are also at high risk because they are in close contact with patients during slit lamp exam and during direct ophthalmoscopy. And Dr. Li Wenliang is a 34-year-old ophthalmologist from Wuhan. He contracted the COVID virus from an asymptomatic glaucoma patient and passed away in early February. He was one of the 3 ophthalmologists who passed away in the same hospital. Next, I'll pass on to Dr. Li to discuss the infection control measures in our eye clinic.
Thank you very much, Tracy. Before we implemented all the infection control measures in our hospitals, we worked closely with all stakeholders. It was based on a 3-level hierarchy approach, namely administrative control, environmental control, and the use of personal protective equipment. As your clinical settings may be different from ours, I suggest you work closely with your local infection control experts before you decide on which types of measures to implement. I do not intend to cover everything in our paper. Please do refer to our paper for further details, and the editors of Gravies have kindly granted free access via this link. Administrative control is the most important as it involves the largest number of people. It aims to reduce the risk of exposure of uninfected people to infected cases. I will go through each of them. First is to reduce attendances at our eye clinic. We have a total attendance of around 500 cases a day in our eye clinics in Hong Kong. To lower attendances, we have been sending out text messages to patients' mobile phones 1 week before their appointments. In the message, we ask specifically for fever, flu symptoms, and recent travel history. And we offered rescheduling through our hotline, and we also offer free drug refill. Responding cases will have their case records screened by our doctors, who will then decide whether to accept the rescheduling and also the timing of the rescheduled appointment. Out of the 10,000 messages sent out in the past month, we had a response rate of around 12%. Patient satisfaction was excellent, and the main reason for rescheduling is patients' fear of COVID-19 infection. Every patient who comes to our hospital are screened by the FTOCC questionnaire. Fever is particularly important, as we know up to 98% of infected cases developed fever. The others include presence of respiratory symptoms, family members or close contact with symptoms, travel to outbreak areas, occupation as healthcare worker or in wet market, and any contact with confirmed cases. Besides, we also ask about symptoms of conjunctivitis, which, as Tracy mentioned, could be the first presenting symptoms of COVID-19. Any positive response will mean postponing their appointment for at least 14 days, which is the current understanding of the incubation period of COVID-19. The IT departments of Hospital Authority and the Immigration Department in Hong Kong have successfully linked up their systems within the last month. A great initiative to allow healthcare workers to obtain more accurate travel history of patients. This is the workflow of our triage system. At the entrance of our clinic, all patients have their temperature checked by triage nurses. If positive, they will be asked to attend casualty department for management. Then they are screened for FTOCC. If positive and their eye condition is urgent, they will wait in a separate waiting area and have their visual acuity and examination conducted in a designated room. If their condition is not urgent or FTOC screening is negative, they will be offered drug refill and rescheduling of their appointment. If they refuse, cases will be seen under standard precaution. To minimize attendances and conserve manpower, all elective procedures and services were suspended. This includes elective cataract surgery, pterygium surgery, and non-urgent subspecialty surgeries. Only emergency surgeries are maintained. To reduce the risk of transmission by aerosol-generating procedures, we have suspended all nasal endoscopy for DCR. As non-contact tonometry can generate microaerosol, its use is suspended, and intraocular measurement should also be minimized. As coronavirus may be present in tiers of infected cases, the use of disposable tips and prisms is highly suggested. This can reduce the risk of transmission during the disinfection of prisms. As we all know, ignorance can be dangerous. Therefore, providing update of knowledge on COVID-19 for our healthcare workers is crucial. It can help to protect both ourselves and patients. To reduce the infection risk between healthcare workers, all staff members are required to report their daily body temperature before work and any recent foreign travel. Social distancing is strongly encouraged. For environmental control, protective shields are installed on all slit lamps. Similar shields can also be installed on portable slit lamps and OCT or fundus cameras. Regular disinfection is mandatory. I would like to acknowledge Dr. Sidaf of the University of Hong Kong for providing this slide. It summarizes the suitable methods for disinfection of COVID-19 for skin and surfaces. Coronaviruses are covered by a lipid layer of envelope. Fortunately, this envelope can be disrupted, rendering the virus non-infectious. As coronavirus can survive on surfaces up to days, disinfection is of paramount importance. Disinfection of ophthalmic equipment, keyboards, tabletops, doorknobs, and particularly mobile phones should be conducted regularly. Bagging of equipment that is difficult to disinfect, such as keyboards, is suggested. Our hospital has recently installed a UV disinfection machine in our canteen to allow our colleagues to disinfect small items such as mobile phones and staff card. It takes about 30 seconds to complete the whole disinfection process. For both staff pantry and canteen, acrylic partitions were installed to prevent droplet transmission during meals for healthcare workers. our nurses have put up these emojis on partition to remind colleagues to minimize chatting during meals. To observe social distancing, all situation update meetings and academic meetings are conducted via video conferencing apps on personal mobile devices. During this difficult time, mental wellness of our colleagues should not be overlooked. For example, our team invited our hospital priest to lead prayers and conduct sharing before we start our weekly meeting. For the use of personal protective equipment, please refer to your local infection control guideline. For general outpatient clinics, we adopt standard precaution, which includes the use of eye protection and surgical masks. When handling high-risk cases or confirmed cases, one should use either goggles or face shield, N95 respirator, isolation gown, and disposable gloves. Do remember to dispose gloves for each case, followed by hand hygiene. So the 7 steps of hand hygiene is very important. You can either do it with the use of hand washing or alcohol hand rub before and after each patient encounter. In conclusion, COVID-19 is transmitted via droplets, contact, and fomites. It is important to remember conjunctivitis can be the first presenting symptom. The use of 3-level hierarchy approach can provide a good framework for infection control. As there is variation of clinical settings, prior consultation with local infection control experts before implementation of infection control measures is highly recommended. I'm leaving my contact. Please feel free to contact me if you have any questions. As individuals, we may feel discouraged in this uphill battle against COVID-19. But on the positive side, as global ophthalmologists, we have never been so connected and working closely together with each other for the same cause. 6 months ago, I could never have imagined I would be working with you all. So I'm optimistic that if everyone takes a small step and keeps love in our heart, we will prevail. Thank you once again. And here's the helpful information that you can refer to. Thank you.
Well, first of all, thank you. I speak for all of us when I say that that was a fantastic presentation, and we are very grateful that you have taken the time to prepare this and to show it to us. So thank you again very much in behalf of all the Council of Ophthalmology in Argentina for this fantastic presentation. So thank you very much.
Yeah, you're very, very welcome. I think during this difficult time, we must work very closely together. Yeah, and exchange experiences. I think that's very crucial.
So we have a couple of questions. Would you care to elaborate what type of telemedicine you are using, if you are using any type of distance medicine at this time?
We in our hospital, we have started the use of teleconsultation over the past month, and it has been mainly done by other disciplines, but we are actively exploring its use in ophthalmology, and hopefully we can start adopting in the coming weeks. So we haven't started yet, but we will.
Okay, thank you. And what about corneal transplants and intravitreal injections? Are you doing those procedures in your clinic?
We have stopped all elective corneal transplants, and we only maintain emergency corneal transplant service, for example, for corneal perforation. And harvesting of corneal grafts by the eye bank has been stopped since the COVID-19 outbreak. And the eye bank is exploring the testing of donor corneas for COVID-19. And normally all patients with fever, elevated white cell count, flu, pneumonia, and sepsis were already screened out and were not eligible for corneal graft donation. And for intravitreal injections, we maintain the service as a delay of treatment may lead to visual loss.
Yes, I'd like to supplement. For intravitreal injection, we also adopt the same screening for fever, travel history, and clustering before patients are permitted into the treatment room. So hopefully that will we will able to screen out the high-risk cases.
Okay, I think you've said this before, but I'd like you to repeat this. How long does it take for a test of COVID-19 to have a positive result, for example?
Currently, we have in our hospital, we conduct 24-hour service for the rapid PCR test. And the turnaround time is around 4 to 5 hours, which is very helpful for us to screen out high-risk cases.
As you may know, Argentina is currently in a lockdown. We are in a quarantine. And as you said, we have 220 confirmed cases. We are probably not doing enough tests for the whole population, so like South Korea is doing, for example. And we had 67 new cases yesterday. Do you think that these are correct measures for the population right now to be in a lockdown, in a quarantine?
I'm not an expert in public health, so it's difficult for me to comment on your question. But I'm sure they are doing their best to minimize the transmission.
And were you at any time in a full quarantine in Hong Kong?
Sorry,
were you at any time during this pandemic? Was Hong Kong in a full quarantine?
No, Tracy, I think is that right? We're not quarantining everyone. No, so it's not at a full lockdown. Yeah.
Okay, thank you.
About intravitreal injections, I know you suspended elective, and you do like the triage and everything that you told us, but you select some kind of patients. Like here, we're just leaving it to patients with one eye or more severe cases, and postponing the other kind of cases.
Yeah, I think that's a great idea. We haven't adopted that. I think that's a very good suggestion that we can consider. As ophthalmologists, it would be a very hard decision to stratify who should get the injection. As we know, they should all improve and at least maintain their vision after injection of anti-VEGF. So I hope we don't have to make that decisions, but it is difficult times. Yeah.
Did you all your ophthalmologists get exposed at the same time? Or did you organize yourself to make shifts?
No. Are you suggesting like dividing the team into like
Right.
Yes.
two separate
Yes,
teams?
that's what he's
Yeah.
saying. If
Yeah.
if all the staff remain the same, or did you make teams? Did you reduce the staff of the hospital for this situation?
We as you could see, we had a reduction in the activities, so we try to minimize the number of doctors in clinical areas as much as possible. So we that's one thing, and in terms of the splitting the team, we have thought about that, but we have not implemented so far. Have you guys in Argentina been doing it, splitting the team?
Yes, in our clinic we have 2 or 3 teams in administration, the OR as well, and they are on call. They are not actively on the clinic, and they are on call if there is for example, one team is Monday, Tuesday, Wednesday, and the other team is Thursday, Friday, Saturday, for example, and it's always the same team. They don't mix. It has been just implemented, so just this week. So we don't know.
I think that's a great idea. Yeah, we thought about doing it, but we haven't. Again, I think because the situation wasn't that bad over the past month, we have the tendency to be a bit more
That's good.
not to take more drastic measures. But I think that's a great idea, Luciano, I think.
And what about the staff of the hospital over 60 years old? Are they working? Are they at home?
We have a retirement age of 60. So it's only very under special circumstances, then you can work till 65.
Okay. But what about at-risk patients, for example, asthmatic patients, or I mean, if you consider someone to be at risk, they are not working, for example, even if they are
patients or healthcare
staff.
workers. Staff. We are thinking about along the same lines. Of course, those who are pregnant or immunocompromised for various reasons, we are hoping to put them in non-clinical areas.
Okay.
Yeah.
In your personal opinion, how do you see this pandemic working lasting? How do you think it will last? Like, for example, in China, which you are now in a kind of controlled situation, how do you see us implementing these measures and consensus at this time of the exponential curve, like in the beginning, because we are now at the beginning of the exponential growth of the pandemic here in Argentina, rather than other country that has implemented the lockdowns and these measures in the highest part of the exponential curve. How do you see us, and how do you see China getting out of the problem?
I don't have a crystal ball. I don't know what's going to happen. I've been reading a lot of different experts predicting what's going to happen, and frankly speaking, I don't know which direction we're going, but it appears that countries one by one will adopt lockdown strategy to contain the infection. So maybe in time, we basically are doing whatever we can to flatten the curve. That's what they said, and try to maintain the critical cases within our capacity. That's what appears to be the lot of general acceptance that it may be the ideal thing that we should achieve. But some of the, I don't know whether you've read about David Ho, who is the AIDS expert in the States, and also Dr. Yun, Professor Yun from Hong Kong, who is also one of the experts in microbiology and infectious disease. They predict that the condition will damp down with time, but will come back regularly. So we just have to await the remedies for treatment for this condition. So I don't know whether I've answered your question, but we just have to try our best and hope for the best.
Thank you guys. See you. Take care.
Thank you very much.
Keep in contact.
Bye.
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 Bye.